Dr. Vickers. Dr. Vickers is one of the first people who I think really shed light on the fact that there were significant health disparities on a national level in regards to the COVID-19 pandemic. And additionally, Dr. Durant has had a very long and wonderful career looking at health disparities across many health conditions for African American populations. I'm going to begin our talk by focusing on COVID-19 and giving a general overview of what COVID-19 is, how it's spreading, and what the domestic epidemic looks like. So here's the table of contents for today's talk. After I'm done doing the overview for COVID-19, we're going to move with Dr. Durant leading discussions about health disparities, what health disparities are, and how it relates to COVID-19 and what we're seeing, like I said, domestically with those disparities. And then we'll move forward with the panel discussion where you can feel free to ask us as many questions as you like based off the presentation and any other questions you may have. So let's start with COVID-19 and what COVID-19 is. So we actually have a lot of experience dealing with coronaviruses. This is something that is a well-known virus that causes the common cold, meaning that we know that there are specific types of coronaviruses, alpha and beta, that typically cause colds, but also with the beta genre of the virus can cause disease that lead to very, very severe infections. So we have two examples of diseases that were similar to COVID-19 prior to this. The first one is SARS. This is severe acute respiratory syndrome. And really we saw this in Asia from 2002 to 2004. The MERS virus, or the Middle Eastern respiratory syndrome, is something that's still ongoing. And based off these two highly infectious, fairly fatalistic viruses, SARS COVID-19 has caused almost double the deaths compared to these two. And that's been going on really just since 2019. So we had our first case documented in December 8th. And the first cluster was identified in December 26th in Wuhan. And then rather rapidly, you start seeing progression of this across the globe, with the WHO declaring a public health emergency January 30th and a pandemic declared by March 11th. So this is kind of where we are today, dealing with this pandemic that's affecting really almost every country across the globe, every continent. So we believe that this form of virus originated in bats as the primary reservoir, and whether there was an intermediate host or not is not clear, but we know that human-to-human transmission definitely occurs, and it typically occurs through respiratory droplets. So that's anything that's coming from your nose, that's landing in your mouth, your eyes, or in your respiratory system. When we're looking at epidemiology, which is looking at how diseases spread across a community, one thing that we've been focused on is the reproductive number for COVID-19. So this is a term where we're saying in a closed system where everyone has the same likelihood of becoming infected with the virus. So there's no vaccines, there's no innate immunity to a virus. How many people can one person infect? And this number can vary over time. So to give you an example, when we're looking at the flu, the reproductive number for the flu is 1.28. Anything greater than 1 means that it has the potential to spread. Measles, which is highly infectious, has a reproductive number of 12 to 18. There have been varying numbers when it comes to COVID-19 and how infectious it is. But right now in Alabama, what's recorded on our Bama tracker is 1.1, meaning that we know that the virus is currently spreading. Typically, if someone is to get COVID, when do symptoms appear? And symptoms typically appear from time of exposure 2 to 14 days after the exposure. And typically by 5 days, you will have some type of symptom. The symptoms that we typically recommend people look out for are fever, cough, and chest tightness. But I'm going to go on in the next slide to explain that we're really starting to understand that there are a vast array of symptoms that we're really just starting to get a grasp on. About 80% of people who get COVID-19 actually have a very mild clinical course. And it's the few that we're seeing high case fatality rates in. And so when I say the term case fatality rate, that's looking at the number of people who have died or the number of people who've been infected who actually have COVID-19. So we know 3 to 4% of deaths have occurred among people who have COVID-19. And the typical reason we're seeing these deaths is due to something called cytokine storm. So when you get infected with COVID-19, with this virus, you have this storm of your body trying to control the virus inside of you that typically occurs 5 to 10 days after symptom onset. This can result in you having severe respiratory distress syndrome, so it makes it very difficult for you to breathe. A lot of people have to be put on mechanical ventilation. We can see clots occur, and ultimately, the worst case scenario, death. So on the CDC, these are the common signs and symptoms they tell people to look out for. Cough, fever, if you have chills, muscle pain, things that sound mostly like influenza, and then some milder symptoms like sore throat, more severe shortness of breath. And something that's popped up probably in the past month or two, loss of smell or taste is a common symptom with COVID-19. What we found, though, is that there are people presenting that don't have any of these symptoms. So typically, if we're looking just for these symptoms alone, we'll probably miss about 20% of people who actually have COVID. And people can present with atypical findings, so diarrhea, something that came out early, but you can also present with a heart attack, altered mental status, chronic kidney disease that's worsening to people having loss of their kidney function, even things like headache and dizziness. So what we're doing in hospitals now, which I think is helping to prevent spread in hospitalized patients, is test everybody, understanding that we're not always going to be able to catch people based off the symptoms that CDC has prescribed us. So when we're looking at the US epidemiology, there's about 2.5 million people in the US who've been diagnosed with COVID-19. And this is likely a big underestimate because, like I said, and especially in the beginning of the epidemic, domestically, we were only testing people who had symptoms. People who died to date, about 126,000 people. And if you're looking at healthcare providers alone, about 85,000 people have been infected, and there's been over 450 deaths attributed to COVID-19. The majority of cases, and this is not people who have died, but just people who've been infected with COVID-19, are occurring from age 18 to 44. When we're doing our testing for COVID-19, and I had the privilege of being tested for COVID-19, it's a nasopharyngeal swab. It actually rather goes pretty far back into, to be perfectly honest, it feels like they're almost trying to poke your brain because they're trying to get such an accurate swab. But typically, when you're doing a swab, the sensitivity of that test, because we're looking for actual genetic materials of that virus, can be low, meaning that you can have some false negatives depending on who's doing the testing and if they're actually doing the testing correctly. Another additional factor is how far from exposure to time you're being tested that can affect that sensitivity rate. But I've seen anywhere from 70 to 80%. Specificity, meaning how many false positives do you have? So if you go in for COVID-19 testing and you get a positive, if that positive isn't correct, it's actually pretty low. So we know that if you test positive for COVID-19, you likely have COVID-19. Looking at predictors for severe illness, so that case fatality number, the number of people we know who have died from COVID-19, the older your age, the higher risk you have of having a poor outcome from COVID. Originally, African-American race was not listed as a prognostic factor for COVID-19. But recently, CDC and WHO have identified that if you are Black and you live in America, you have a higher likelihood of having a poor outcome if you get COVID-19. Men typically have worse outcomes, and then a few other health conditions we see do not do well if they get COVID-19. So obesity is a big one. We know that people who are obese, unfortunately, typically do worse. If you have underlying heart disease, diabetes, kidney disease, anything that puts your underlying organs at risk from a disease that we know attacks aggressively our organs, puts you at risk for having a bad outcome. And as the pandemic and epidemic domestically is occurring, really we've seen very big shifts in what states are seeing the highest cases. So originally in Washington State where we were seeing our first cases, and New York fairly soon after, and those were the hot spots. But as the epidemic has moved on, we've been seeing significant outbreaks and clusters in Florida, Arizona, California, you'll see them in the news, and our current state rates have also been increasing. And so what this map is showing you based off color, the darker the color, the reported more cases. And then in the above higher map where you see the reds and oranges, this is specifically showing us the hot spots. So if you look at it based off of the counties that are dark, dark red, those are the ones that are seeing the highest rates of COVID-19 spread. And you can see as example, Miami in Florida, Jacksonville in Florida, those places are seeing a lot of spread right now. So you wanna, from a public health standpoint, have very strict guidance to prevent future spread in those locales. Things like having face masks and trying to do really aggressive social distancing. So that 6 feet apart, not having people in rooms with more than 50 people. And this is the data for Alabama. We were joking before we got on the call, but I've had to update these slides on a day-by-day basis because the numbers are shifting so quickly with more and more people becoming infected with COVID-19. So in the state, we talked about this reproductive number. So this right now for our state is 1.1. So we know one person will infect potentially 1.1 people in that closed system that we discussed. We have 900 people that have died from COVID-19 in the state and over 36,000 cases. And I want to emphasize the fact that this is likely an underestimate because we know that people are often asymptomatic or pre-symptomatic, and that results in them not getting tested or getting delayed testing. So these numbers will likely continue to increase unless we have really aggressive public health measures put in place. So that's the real, I think, gist of what COVID-19 is, what we're seeing from an epidemiologic standpoint, and now we're going to move into what health disparities look like and why we're seeing such high numbers in the Black community. So I'm going to turn this over to you, Reagan. Just let me know, Dr. Durant, when you need me to advance the slides.
Dr. Durant, you're muted.
Sorry. Thank you, Carmel. Save me from myself. Thank you, Dr. Lopre, for that that introduction on, more than an introduction, pretty thorough summary of the state of the pandemic, both globally and domestically. Good morning, everyone. Happy to be with you this morning. I'm going to start by just giving a couple of textbook definitions, so to speak, of health disparities. The Institute of Medicine, in a seminal work dating back to 2003, but still pertinent today, describes disparities in healthcare as racial or ethnic differences in the quality of healthcare that are not due to access-related factors or clinical needs, preferences, or the appropriateness of intervention. So put more plainly, the Institute of Medicine definition focuses on those differences that are not necessarily due to understandable variations based on patient preferences or clinically what's needed, but true differences that can't be explained otherwise. And then the working definition from the CDC Health Equity Working Group frames it more through the lens of health equity, and they describe it as a fair distribution of health determinants, outcomes, and resources within and between segments of the population, regardless of social standing. And we're going to talk a little bit about one key word in that definition, determinants, a little bit in a few slides from now. Advance, please. So I wanted to frame health disparities a bit before we started looking at disparities specifically related to COVID-19, just to make sure we sort of all were on the same page. I suspect that you all have been exposed to this term. Many of you may be very familiar with it, but I wanted to, in addition to providing the definitions, give you sort of tangible examples of what this looks like. So a bit of a case study here, a tale of two counties. I'm not going to go quoting about it being the best of times and the worst of times, but in some respects that is apropos in this case study. On the map on the left, you see a map of the state of Alabama, and you see two counties highlighted there. One is Autauga County, which is the one most northward, and then immediately to the south you see Lowndes County. And these counties are interesting because they're geographically adjacent to one another, but very different. Autauga County, for the longest, has been mostly rural, as has Lowndes, But the difference is Lowndes is part of what's called the Alabama Black Belt. And the Black Belt, the terminology originally in the mid 19th century, even probably dating back farther than that, but certainly right up to the Civil War, the term was referred to the rich, fertile soil in this region. And this soil provided for lots of farming and lots of farming done by slave labor prior to the Civil War. And there are a number of counties, and it really is a belt of counties across central Alabama. Following the Civil War, and then on with the Industrial Revolution in the early 20th century, many of these counties at the peak of slavery had African-American residents that outnumbered white residents, though the African-Americans obviously at the time, the slaves at the time were not counted as citizens, but they still outnumbered whites. With the passage of time and the pivot away from farming, many of these counties fell on hard times, though they were still mostly populated by African-Americans, many of whom were the direct descendants of slaves. So Lowndes County is one of those counties that shares that history. So I want to do a little bit of comparison here and hopefully can illustrate sort of why we think about health disparities and how we approach them. So Lowndes is much smaller in population, as you can see, although geographically they're roughly the same size, but has almost just barely 20% of the population of Watauga County. You can see the racial difference in racial makeup, whereas Lowndes is about over 70% African-American, Watauga County is barely 20%. And then you look at the COVID rate. So this is a rate based on the last 2 weeks up to yesterday. And it's almost, it's over double in Lowndes County what it is in Watauga County. And again, two neighboring counties. Pivoting away from COVID a little bit, but you look at diabetes prevalence, higher in Lowndes County than Watauga County, just barely, but higher just the same. And then you look at obesity prevalence, much higher in Lowndes County versus Watauga County. So these sorts of things begin to demonstrate how some of these differences in populations manifest themselves. And you can see that it's not limited to COVID-19. Obviously, the diabetes prevalence and the obesity prevalence, given what we know about the chronicity of those two, one is a disease, one is a risk factor, but they don't develop overnight. These disparities probably long preceded the pandemic. Next slide. So looking a little bit deeper in this comparison of these two counties, we tend to sometimes zero in on race when it comes to looking at disparities. So oftentimes we are focused on racial differences. But you'll remember in that CDC working group definition, the word determinants. And the reason I'm harking back to that term is race is one of only many determinants. And we often refer to a term called social determinants, which some of you may be familiar with. And these really are the factors that exist in our environments, whether they are our physical environment or our psychosocial environment. But they're all factors that oftentimes have a big impact on our health outcomes, sometimes even more so than the actual care that we receive as patients. So this slide illustrates some of those determinants and how they differ in these two counties. So you look at the ratio of the population to primary care providers. So you see it's almost 5 times the ratio in Lowndes County. So what this means is that for every 10,000 or so residents of Lowndes County, there's one provider. Now you saw the population was about 9,000. So I mean, you can extrapolate that means that there are probably 1 or 2 primary care physicians in the whole county. Whereas in Watauga County, for every roughly 2,000 people, there's a primary care physician. When you look at education, what's interesting is in terms of high school education, they're relatively equal, but then you see a big divergence when you start looking at folks who have some college. Only 35% in Lowndes, whereas 62% in Watauga County. And then you see really on down the line, disparities all in the same direction. Higher household income in Watauga County, lower unemployment, and these unemployment numbers are pre-COVID. They're probably worse in both places, but I would not be surprised if it's still roughly a twofold difference, even with both being worse. Uninsurance rates higher in Lowndes County. Food insecurity, meaning people's ability to have adequate nutrition and sustenance by way of food, that's higher in Lowndes County. And then severe housing problems, and that was defined as having any number of self-reported problems with housing, like no running water, difficulty maintaining housing, and again, that factor is higher in Lowndes County compared to among people in Lowndes County compared to Watauga County. So again, you can see that it's not just a difference in the racial makeup. There really are differences in all of these factors, and collectively, these factors may contribute to some of the disparities that we see in these two counties in terms of outcomes. I chose Lowndes and Watauga County because we're here in Alabama, and I'm relatively familiar with those two places, but the likelihood is I know there are lots of states and even folks from Puerto Rico on this call. I suspect that in each of your locales, we could probably choose two areas, whether they're counties or sometimes even more granularly neighborhoods, and find some of the same differences. So these are two examples, but it's not limited to Alabama or to these two counties. Next slide. So now I'm going to focus a little bit on COVID-19 and disparities related to the pandemic. Next slide. So this is the message from Dean Vickers, who obviously is on the call, and it was issued earlier this month. I'm not going to read the statement. It really is, I will tell you what I took away from it. I thought it was powerful in the sense that we talked about, it certainly referenced disparities that we were all aware of. I think it went a step further in a number of ways and really contextualized those disparities through the lens of racism. And so these disparities oftentimes don't exist in a vacuum. Unfortunately, there are downstream implications of racism, and we have to acknowledge that. And I think Dean Vickers did a good job of putting that front and center, and then challenging everyone. So many times when these discussions are had, oftentimes they can be had with just a limited few. So it could be just the underrepresented groups or the minority groups, and not just minority groups by race. It could be minority groups based on gender or sexual orientation. It could be based on socioeconomic status, whatever that defining characteristic is. Oftentimes the discussion is limited to just that small group of people, whereas this statement really challenges us as an institution for us all to be participants and really look inwardly and figure out what each of us can do, regardless of our backgrounds, to try to address this issue, not only for our patients, but also more globally for society. Next slide. So this is a slide looking at cases by race and ethnicity, and I think this is one that Dr. Lopre showed earlier. She was focusing more on the total numbers, and I will zero in on the racial differences here. You can see the majority of cases are still comprised of whites, but then you can see a fairly high number of Blacks and Latinos comprising, roughly 60% of the cases, much higher than their respective representation in the overall population here in the U.S. Next slide. So this slide looks at inequities in COVID-19 deaths in smaller areas. You know, what you all perhaps have seen or read, that COVID-19 is killing African Americans at a disproportionately high rate, and this is illustrated in these line graphs here on the left. So each box, so to speak, represents a different locale. Some are cities, as you can see. Most are states, and then there's DC as well. And on the left vertical axis is the percentage of the population that's represented by African Americans. On the right vertical axis is the percentage of deaths represented by African Americans. And you can see in the top left example in Milwaukee County, Wisconsin, African Americans represent 26% of that population, but 73% of the deaths. You know, just eyeballing this with that framing, you can see that none of these lines slant downward from left to right. They all slant upward, even if only slightly, meaning that the proportion of deaths is always higher than the proportion represented in the overall population. And that cuts across, and you can see these are geographically disparate locales, really spanning a good bit of the U.S. And the CDC really summed this phenomena up nicely by stating, you know, longstanding systemic health and social inequities have put some members of racial and ethnic minority groups at increased risk of getting COVID-19 or it's experiencing severe illness regardless of age. So again, hearkening back to the disparities that we saw comparing the two counties, the long-standing disparities, for instance, the examples I gave you were diabetes and obesity, though there are many others, you know, may be contributing to some of the worst outcomes that are being seen in places like Lowndes County compared to outcomes seen among those infected in places like Atauga. Next slide. So this just looks at the demographics, not only by race, but by other factors. If we look at age, we can see that in the top left, that roughly 40% of the cases are comprised of adults aged 25 to 49. If you're moving to the right, you can see ethnicity. Again, we've already discussed that most of the cases are among non-Hispanics, but a pretty healthy sample as well among Latinos. Gender, women, the cases are represented more by women compared to men. And then we've already talked on the bottom right about some of the representation by the different races. Again, the take-home message here is you see African Americans in Alabama, not unlike those other, not unlike the nationwide numbers that we talked about earlier. 38% of COVID cases in Alabama represented by African Americans. And that's in the context of African Americans representing roughly 25% of the overall population. So you can see disproportionate number of cases among African Americans here in our state, in Alabama. Next slide. And then when we look at deaths in Alabama, unfortunately a similar story. You can see age and ethnicity across the top, gender roughly equal, more equal than when we looked at just those infected or the case rate. But then again, when we get down to the bottom right and looking at deaths, 45% of the deaths are among African Americans. So again, an even higher proportion. It was about 40% on the case rate, but 45% of the deaths among African Americans. So again, once infected, African Americans are more likely to die from COVID-19 than other groups, and therefore represent a disproportionate share of the deaths. Next slide. So we'll end with this quote. One of the things that I think we all have have begun to explore more in probably the last 10 years. In so many instances, we focused on MLK's legacy almost exclusively in the vein of civil rights, and civil rights defined somewhat narrowly by rights in public spaces, rights to vote, and those other forms of civic participation. But he really was also focused on a whole host of other things that also would fall under the broader umbrella of civil rights, economic inequality. It seems as though now, some 50 years later, the rest of the world is sort of catching up to his thoughts about that, and also healthcare. And this quote exemplifies that. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And those of you who know, he was assassinated in 1968. So think about how much time has passed in the interim, and that quote still holds true today, unfortunately. So with that, I will end, and I think Carmel is going to give us some guidance on opening up the panel discussion. Looking forward to hearing you all's thoughts or questions.
Thank you, Dr. Duran and Dr. Lopre. Right now we can open it up to a general discussion. If anyone has a question, if you'd like to write it in the group chat, or if you would like to unmute yourselves, I'll call on your names when I see your microphone unmuted. So does anybody have anything they would like to? I'm sorry, Dr. Duran.
And Carmel, I'm sorry, I was neglecting not asking Dr. Vickers if he had anything that he wanted to add to our presentation. My apologies, Dr. Vickers.
No, no issue. I will only comment that I think both you and Dr. Lopre have, in a very powerful way, given one of the best presentations I've seen on this topic, thoughtfully given, data-driven, and with a clear understanding of the issues. So I appreciate it very much. I'm very proud to see it, and it's very well done.
Thank you.
Thank you. At this time, does anybody have anything they would like to ask? So Sydney, would you like to ask your question out loud, or would you like me to address it for you?
I can ask it out loud. I was wondering if the reason why African Americans were like getting COVID-19 much faster than other races was because of the lack of health care.
So I think, thank you for that question. That's a very good question, and I think it's one where we're trying to answer. As Dr. Lopre mentioned, it's only it's only been recent that African American race in and of itself was thought to be a risk factor, for instance, for having worse outcomes for COVID-19, and African American race independently being associated with worse outcomes. So we know that more African Americans are obese, more have diabetes, and so any relationship between worse outcomes and race, might be due to the fact that African Americans have those, oftentimes have those other health problems. But it seems as if, even aside from that, it tends to portend for worse outcomes. So why African Americans? So that's related to, once folks are infected, how well they do. But why African Americans have such a high rate of infection? So are they more likely to get the disease? I think that's something that we're still grappling with. The difficulty in answering that question now, and Dr. Lopre also alluded to this, it's so difficult to really figure out who has been exposed and who has not. I think as we get better at that, and as we can identify people who perhaps were infected but didn't have symptoms, we may be able to better answer that question. That being said, there are some theories that may explain why African Americans have such a high case rate. So given that, I'll speak about Alabama, but it probably pertains nationwide. Here in Alabama, African Americans are disproportionately poor. What I mean by that is a higher proportion of African Americans are poor. Doesn't mean all African Americans are poor, but a higher proportion compared to whites. That means that in many cases, they tend to work in jobs that do not have the flexibility of working at home, for instance. And so they may incur more exposures because while I may be able to do some of what I do, if not a good bit of what I do from home, someone who is in a manual labor job may not have that option, and that person may have to venture out and therefore may be exposed more. They're also, you know, again, related to poverty, there may be people who are living in multi-generational households. So the ability to social distance just may be limited in some households, more limited in some households than others. And then if you've got a number of people who are having to go out and work and then coming back to the same, that again, these are theories. We don't have enough data yet to say whether or not these things are definitively true, but those could be some explanations as to why African Americans are more likely, or that may contribute to the higher case rate among African Americans. Right now, we don't know, and I want to make this clear, we don't know whether or not there is something biological right now. So I want to emphasize that. You heard me sort of focusing more on social factors. At the time, and Dr. Lopre can jump in if I'm misspeaking, we don't necessarily know that there is some biological mechanism that makes African Americans, that explains a higher case rate.
Along those lines, I was also going to ask if there's, I know it's probably too early to tell, but are there any genetic markers, or is that being looked at right now for disease susceptibility?
So I'll comment to say that the large genome study called All of Us is now going to begin to look at determining whether there are any potentially genetic predeterminants that might put people at greater risk. I think, as Reagan said, it's clearly not evident now. But I do think in the context of what he said is true, people have inferred that when a population, as he's described, are heavily involved in what's called essential activities, which means you have to go to work. Number two, the way that you get there is on public transportation, which has been correlated to increased infectivity. In addition, that's typically also related to living in a high density area with multiple people going in and out. Those factors probably would make anybody more susceptible to get the virus. And then if you add the fact that those areas were often least tested initially, you have a recipe for a group to be disproportionately with higher cases. And then if you add their chronic diseases on top of that, of their disparities, you now add a greater risk of death. So all the things he talked about, whatever color you were, you would have a difficult outcome if you were falling into all of those categories that simply exposed you to a higher risk of getting the virus. And those are sort of the summary of things that when you look at areas where African Americans, whether in Wisconsin or New York or in Alabama, we fit that paradigm better than most because of the social determinants that we face and the impact of our way we had to work and make a life puts us at greater risk. The final thing I'll say about that, though, is that I think we have historically been able to push social determinants of health as a problem of self-determination of a race. You just haven't done enough. You haven't, grabbed your bootstraps hard enough to pull up. And if you did it, it will be better. This virus makes it clear that if you don't take care of the people who live in Lowndes County, it will eventually affect the people who live in Otaga County. So the most vulnerable population, if you don't take care of that vulnerable population, they will eventually end up affecting those who are the haves versus the have-not. So you can't ignore those who are poor and of different color and expect to improve the outcome from this virus.
Thank you. Anna has a question. Would you like to unmute? And then Salvador.
Yeah, I was just wondering what your thoughts are on discrimination leading to adverse outcomes. I recently heard a talk about how people, regardless of their socioeconomic background, if they face racial discrimination when they're younger, then it leads to adverse outcomes later on in life.
So I can comment. We do know that when you're controlling for other factors, looking just at the experiences people face and the stress from racism, it causes higher mortality rates and worse outcomes in general. I would say on an individual level, as all of you are soon to be hopefully future healthcare providers, we also know that bias plays a role in who's being tested and who's being hospitalized. And right now, on an individual basis, there have been case reports coming in of people who reported with symptoms that were consistent with COVID who were turned away. And I think from a larger perspective, we can probably assume, because we've seen it with other health conditions, that that's playing a role in some of the inequities we're seeing. So as an example, if someone's coming in complaining of chest pain, if you're coming in and you're Black, you're less likely to get a invasive procedure to open up blood vessels to prevent worsening damage of your heart. So I think on an individual level, for healthcare providers, having education that focuses on implicit biases can also play a role in avoiding some of the outcomes we're seeing.
Salvador had a question, comment.
Yes, hello. My question was just if there was a good way to make people understand that wearing masks is important.
So, Salvador, if you've been watching the news, I think if we knew the answer to that question, we would be a lot better off nationally than we are right now. I think, you know, unfortunately, I'm not a psychologist, but I think there are a number of factors, and we could spend a whole hour talking about some of those factors. Some of them probably more political than behavioral, though it's hard to sometimes disentangle those two realms. But I think from the behavioral standpoint, there are times that we find in medicine, and it's not just the pandemic, where people just don't appreciate the risk to their health until they are personally touched by that risk. So if it means that they are stricken with the disease, if it means that someone close to them is stricken with the disease, sometimes the risk just can seem very abstract. And I think in some respects, it was unintentional, but we probably did ourselves a disservice early on by stressing how the higher risk among the elderly and those who have chronic conditions, because I think it created a false sense of comfort among those who did not fall in those categories. Of course, also those folks also oftentimes overlooking that even if they were okay, so even if they only had a mild to moderate illness, they still were putting others at risk. So long way of saying, you know, I think just getting people to appreciate the risk to themselves and the risk to the others in the absence of mask wearing. But sometimes that is an abstract concept that it's hard for folks to grasp.
Absolutely. So thank you. Amber, you have a question?
Yes. In the slide that Leticia mentioned on predictors of several illness, you mentioned that male gender has have more risk than women to get COVID-19, and why is that?
So that's a predictor of poor outcomes. And I'll say that typically when we're looking at these types of studies, we're looking at associations. So I can't say for sure that genetically speaking, because of your gender as male, that's why you have poor outcomes. It could be because men have higher rates of hypertension, diabetes, or obesity that are putting them at risk for having worse outcomes related to COVID-19. So typically when they're providing that list for you of all the things that are predictors, that's not a direct causality, it's an association. And it's just helping us to identify people who we might think might have greater risk of poor outcomes in general. That answers your question.
Thank you.
Yes, thank you.
Alyssa?
Hi, thank y'all for taking the time to come out and speak to us. So I guess I put my questions in there, but I guess especially with like kind of recent events surrounding race as well, as we've seen in the news kind of come to the forefront even more so than they have in the past. And then also with COVID kind of revealing a lot of the, I guess, shortcomings of kind of our healthcare system. Like what conversations have y'all seen be kind of good from this ongoing pandemic, or what conversations would you like to see that haven't necessarily been talked about enough, like in the future?
So I'll take a stab at it, and just since we only have a few minutes left, I'll try to be very brief. So one area, and Dr. Lopre perhaps can attest to this, we will be much better situated to provide care long distance now than we had been previously. There was a burgeoning area of telemedicine, so using telephone or even something like a Zoom platform. It's not Zoom, but something akin to that, to interact with patients. That's probably been accelerated. If you talk to people who are far more expert in this than I am, that progress has been accelerated probably by about a decade in the last 3 to 4 months, because we've had to do that. I think more specifically related to race, I think it's just another example of, and Dr. Vickers touched on this, we have groups of individuals in our society who chronically are not doing well relative to their health care. And we can choose to ignore them or choose to continue to acknowledge that they're not doing well, but not put forth the adequate effort made to close those gaps. But it manifests itself in times like this, because when there is something that affects everyone, those people end up being disproportionately affected. And in some cases, actually in many cases, that spills over into the broader group. So with diabetes, there are ways in which it spills over: healthcare costs, lost productivity, that it affects society, but it's very tangible with the communicable disease, right? So if somebody, for whatever reason, because of his or her circumstances, is not able to protect himself or herself from the communicable disease, and then they contribute to the spread, which in turn endangers everyone, that's a very different paradigm. So I think my hope is that it will accelerate discussions about how to fix this problem at baseline, rather than waiting for these kind of once in a lifetime events. And who knows, this may not, given sort of the global nature of the world we live in, we may see this again at some point in all our lifetimes. And that is, so making sure that as a society, we aren't allowing some groups to remain so vulnerable to disease, and in turn, making all of us vulnerable to a pandemic or some other event like this.
So with regard to telehealth, so it's one thing talking on the telephone, most people have access to that, but for the Zoom-like calls that you mentioned, you have to have internet and computer access. Is it going to be likely that there'll be offices available where people can go, rather than seeing the doctor, they'll have access to those technologies?
So again, I'm not the expert, but I think one one sort of aspect that we all want to be cautious about in thinking about the acceleration of telehealth is making sure we don't widen the gap, right? Mm-hmm. So if we think just about socioeconomic status, and we know that in general, being poor is not good for your health. And that's a sweeping generalization, but in many, we could come up with many specific examples to demonstrate that notion. So what we'd hate to do is for those who maybe, can't afford Wi-Fi in the home, or who can't afford an unlimited data package on their cell phones, we'd hate for those people to have even less access to their providers. So I think in accelerating the use of telemedicine, it's going to have to be done in a thoughtful way. So it's not, and that's true of almost any innovation in medicine. We find ourselves struggling with this on multiple fronts, because any scientific discovery that changes the way that we care for patients, if it's not equally accessible, it always has the danger of potentially widening that gap. And practically speaking, what would be nice is if there were some public sector investment to give people equal access to Wi-Fi. That would go a long way. So if we as a nation decided that just like the public sector delivers water to everybody's home and electricity, and that's a combination of the public sector and private companies. But if we could take that approach and say, you know what, at this point, Wi-Fi is something everybody needs, and we're going to invest in it, that would be the kind of step that would potentially mitigate any differences that currently exist in terms of access.
Can I just add one thing? I know we're closing, but Dr. Vickers hopped off the call just now. I wanted to thank him, because I think what this has taught me, and what I think is teaching most people, is when you have a fractured system at baseline, if you have a broken, inequitable system, any public health emergency is going to widen the gap and inequities that you see. So I think that one of the great things he did is he opened up the discussion for us to focus on the fact that with COVID-19, we were seeing those fractures, and it was exacerbating death rates among people who are highly vulnerable in America right now. So any public health emergency in the future, I think we need to be aggressive in trying to make sure that we are taking care of our vulnerable populations that we know are already trying to navigate a broken system.
And Drs. Lopre and Duran, I can't let us finish without saying I still have family members who are afraid to go to the doctor. I still have family members and friends who don't trust the healthcare system. And it makes it very difficult, especially right now when you know that there are people who are that close to you, who you know intimately, who you know are good people, who are law-abiding citizens who pay their taxes. They're simply afraid to go because they don't trust. What do y'all?
That's a great point. I think, my day job, I take care of people who are living with HIV, and we commonly talk about medical distrust. I think that lack of trust is real, and it's been earned. It's not something that's happened out of nowhere. And I think that as healthcare professionals, it's going to take us a lot looking at our systems to make sure that people who have been wronged by the systems want to trust us. So I'm not sure if that's going to change with this pandemic, but hopefully over time we can improve it. What are your thoughts, Reagan?
I would say the same thing. And the interesting thing, I can speak for myself. The fascinating thing is that we aren't even immune to that distrust. So I think there's sort of this idea that the distrust is based on racial discordance between patient who perhaps is a member of a minority group and a provider, and sometimes even an entire staff, quite frankly, that doesn't look like them. But the fact of the matter is, I know that I'm not even immune to that, because increasingly the gap between those folks who are able to engage in healthcare regularly and feel comfortable with it, and the folks who aren't, is so wide that even just coming in and seeing a face that looks like yours doesn't necessarily bridge that gap. And that's I think, going to force all of us to really think long and hard about how we engage people with care, and then how they access that care.
And even medical students have asked me, just in the last couple of weeks, as I have been in and out of the office, if a vaccine were found, would I be willing to take it this early on in the stage? You know what my response was? It's too early. I'll have to wait.
Yeah.
And I'm sitting in the middle of the medical school, and that was my response. But that's
don't get us started on uptake of flu vaccines. Maybe Dr. Lopre has powers of persuasion, but
she's feeling the pressure.
Yeah, in my clinic, that's so hit or miss. People that go to the ends of the earth for their other healthcare problems, for their active healthcare problems, but they are not taking that flu shot. It's an interesting dichotomy.
That's a whole nother conversation.
We need another hour.
Yeah.
Well, I want to be mindful of your time. We've already run over, and we truly appreciate you joining us this morning. Sorry that Dr. Vickers had to leave before we could thank him, but we'll certainly send an email to thank him for joining us. And thank you to Dr. Lopre and Dr. Durant. We really appreciate the discussion. It's an evolving problem, and I think if you were to give this talk tomorrow or next week, it would have different statistics, and
yeah,
hopefully they start to decrease. Hopefully we can start to see a decline in those numbers. But anyway, with that, I'd like to thank everyone for joining us this morning. For the students, we'll have Mr. Arsenault joining us for financial planning in about 20 minutes or so. But thank you again. We really, really, truly appreciate you.
Can I get one quick picture of everyone who's still here? Videos on, so I can get a couple of pictures for our social media. Dr. Durant and Dr. Lopre, if you don't mind, and Dr. McNicholas, if you can use your camera as well, if you have a larger view.
Caroline's our resident David Bailey.
All right, on the count of 3, 2, 1, smile. Excellent. Next page. On the count of 3, 2, 1, smile. And again, next page on the count of 3, 2, 1. Awesome. Thank y'all so much.
Okay, thanks once again. Thank you so much. We really appreciate you joining us. And with that, we'll close this. Thank you. Have a good day, everyone.
Thank you so much.